Welcome to Deep Dive Dialogue. Our topic for today is shaping personalized care in colorectal cancer, advances in genomic biomarkers. Advances in genomic biomarkers are revolutionizing personalized care and screening in colorectal cancer. By identifying specific genetic mutations, clinicians can tailor treatment and screening protocols to individual patients, enhancing efficacy and minimizing side effects. This precision medicine approach not only improves outcomes but also fosters innovative strategies for early detection and management of disease. Today we have with us Dr. Shravan Nadkarni. He is consultant surgical oncologist at Balco Medical Center, a unit of Vedanta Medical Research Foundation, Raipur, and he has done MCH surgical oncology from Tata Memorial Center, Mumbai. Welcome, Dr. Shravan.
Thank you, Dr. Manisha. Thanks a lot for the welcome.
Yeah. So, can you tell me that what colorectal cancer is and who is at risk of developing it?
Thank you for having this webinar about colorectal cancers because we, as I see it, are standing at the cusp of a significant rise in colorectal cancers, especially in our country, which is, so to say, trapped in sort of westernization of lifestyle. The food habits, everything is changing, and it's kind of showing up in our day-to-day practice. So world over, we see colorectal cancer to be the third commonest cancers affecting both men and women. In India, however, the scenario is pretty different and in a way a little alarming as well, because we are seeing a lot of young colorectal cancers in India, and the incidence is definitely rising. And we see a lot of patients who come to us with complaints of alteration in bowel habits, uh, maybe just a change in the regular bowel habits that they are experiencing, up to and not limited to something like bleeding that is happening through in the bowels. So in the stools, I'm sorry. So there are varied ways how colorectal cancer presents. To speak about colorectal cancer per se, so for our audience who don't understand the anatomy of the body, so we have the gastrointestinal tract, which has the colon and the rectum, which helps in producing and excreting the human waste. And these are the subsites where cancers can develop. And these are, clubbed into one group called colorectal cancers. Most of the colorectal cancers develop due to sporadic nature. That is, it is not the genetic thing which is most common. We have patients in the OPD who come and say that none of our family members have had a colorectal cancer. Then how is it that I am developing this? So most commonly it is sporadic, which is not related to genetics or family. Uh, of course, the genes are responsible, but that is not to say that it is passed on from generations in the family. So the most common risk factors for colorectal cancers per se are, smoking alcohol always, figure in the risk factors. Obesity is a very big risk factor for colorectal cancer. A diet which is deficient in fibers, diet which has a lot of red meat has been implicated in the development of colorectal cancer. Uh, and as I mentioned, there are also syndromes that are instrumental as far as colorectal cancers are concerned. The most common are Lynch syndrome, which is also known as the hereditary non-polyposis colorectal cancer. There is the familial adenomatous polyposis, that is FAP, and there are variants of these genetic syndromes, and these are usually implicated in development of colorectal cancer.
Right. So, what are the commonly used methods for screening individuals for colorectal cancer?
So, why we are talking about screening today is because colorectal cancer has significant morbidity and mortality with a lot of productive man hours which are lost. And the sure shot way of reducing mortality with colorectal cancer is to catch these cancers at a stage where cure is possible. So it's like there's a very well publicized Vogelstein's seminal work on this topic, which talks about the adenoma carcinoma sequence. To give you an idea, I need to talk a little bit about how it develops. It might become a little technical for our viewers, but then I think it's imperative for them to understand this. So there are predominantly three pathways by which colorectal cancer develops. So one is the chromosomal instability pathway, one is the microsatellite instability pathway, and the other is the serrated adenoma pathway. Most of the colorectal cancers that we see, about 75 to 80%, are from the the chromosomal instability pathway. So usually this starts as an adenoma or a polyp, so to say. Polyp is just like a outpouching or a small nubbin sort of a thing that develops in the colon. And over the next 20 to 30 years, it can develop dysplasia and then develop into cancers. So this is a stepwise progression of a benign appearing lesion which undergoes some sort of genetic mutations and then takes the form of a cancer. So we have about 10 to 20 years where we can catch these tumors, and tumors in the sense these lesions more appropriately, treat them, and that has shown to reduce the mortality from colorectal cancer and from colorectal cancer ever developing, in fact. So the chromosomal instability pathway is, as I said, the most common and has about a 20-year lag period before the colorectal cancer actually develops. So this gives a very good opportunity for us to screen patients, screen general public, and get an idea about their risks for developing cancers. Again, the general population is classified into average risk individuals and high risk individuals. So average risk individuals are people above the age of 50 who have had no personal history of colorectal cancer, no family history, no history of adenomatous polyps, are usually asymptomatic and are in the general public. So these are the average risk individuals. The higher risk individuals are those who have had a history of colorectal cancer in the family, either a first degree relative who has had colorectal cancer within below the age of 60 years, or two first degree relatives who have had colorectal cancers at any age. So these are first degree relatives. So this is where the family comes in perspective. So any family which has had a history of colorectal cancer, that family would need a higher, would be put in the higher risk strata as far as screening is concerned. Also, higher risk also includes people who have had a history of adenomatous polyps on a colonoscopy. So evidently, the screening guidelines are different for both of these. The average risk individuals in the general population, they go through a different regimen of screening as against the high risk individuals. So the modalities that we have today for screening include a FOBT, that is a fecal occult blood test, which is guaiac based, and there is the fecal immunochemical testing, that is FIT. The flexible sigmoidoscopy, which is a lighted tube that is passed into the rectum of patients which we are screening. The colonoscopy, which is the gold standard method of doing the screening, where the lighted tube is passed through the entire colon, and we are able to see any lesions that are there in the entire colon, address them, and get an idea of what those lesions are. So these are the gold standard ones which are traditionally used. For average risk individuals, the recommended schedule is anybody over the age of 45 should get an annual FOBT, that is a fecal occult blood test, or an FIT. And this is usually done with 3 consecutive stool samples and 2 samples each. And anybody with a positive test goes in for a colonoscopy. So let me tell little bit about the fecal occult blood test and the FIT, because we need to dispel any sort of concerns that people have with regards to screening. It's a stool-based test, so it's not invasive. It's not going to cause any pain. It's not going to be discomforting or anything like that. What the occult blood test does is to detect the heme component of hemoglobin. That is, what we have seen is initially there is blood in the stool which is not overt, so it is not seen, but you can find traces of hemoglobin that is in the stool. So the fecal occult blood test helps in detecting the heme part of the hemoglobin. while the fecal immunochemical testing tests the globin part. So that is the proteinaceous part of the hemoglobin. So basically, what it tests is it tests for the presence of blood. Now, herein comes the role of dietary and drug restrictions as far as FOBT is concerned, because people who have had red meat or beetroot or some raw vegetables or fruits can develop a false positive result. So I think before going for a FOBT test, the patients would need to consult their practitioner, the clinician, who would advise them about specific dietary restrictions. So the FOBT and the FIT, as I said, is an annual test. It is done annually, recommended as far as the US Preventive Services Task Force mentions, is annually after at the age of 45. This is true for FOBT or FIT. Whereas the flexible sigmoidoscopy is done usually 5 yearly, and a colonoscopy is done every 10 yearly. So the flexible sigmoidoscopy only evaluates the distal part, that is the end of the colon and the rectum, to put it in layman terms. While the colonoscopy is able to evaluate the entire colon, including the rectum and the proximal part. Any lesions that are found can be addressed. If there is a polyp that can be excised, we can evaluate the histopathology, and then we can go ahead. So this is as far as the screening modalities and the protocol are concerned.
Correct. So, since genomic screening tools are also coming up, so I would definitely like to know that how they are different from the traditional method and what value they are adding to the early detection.
Right. So at the beginning, when we spoke about the evolution of adenoma and carcinoma and all those things, so there are specific genes which get disturbed or mutated, so to say, in this pathogenesis of colorectal cancer. So you have the index mutation in the APC gene, which is most commonly seen. Then you have the KRAS gene. Then you have the DCC and the P53 and all these. So uh, uh, these are the genetics, the genes which are involved in the development of colorectal cancers. So, what this tells us is that cancer, colorectal cancer especially, or any other cancer, if you say, the problem lies in the genes, and that is how these cells acquire certain characteristics because of which they turn cancerous. So, this affords a very good opportunity for us to evaluate uh, asymptomatic, average risk, healthy population and see whether they are prone or at risk for developing cancers later on in their lives.
Mhm.
So, as far as genomic screening is concerned, the problems with the current screening modalities, they either take the stool samples like the FOBT or FIT, or they're invasive. So, in the sense that the patient has to undergo a colonoscopy or a flexible sigmoidoscopy, and that is inserting a lighted tube into the colon of the patient. Of course, they are gold standard in the sense that we are able to get biopsies and tissue for evaluation. But the focus is on genomic screening because we know that the problem lies in the genes, and that is where we are able to pick up these genes and find out whether the patient or the person who is being screened is at risk. So we have various genomic screening modalities which are under evaluation, including samples from the saliva, the blood, the tissue, the colonic tissue, or even the stool. So you have various microRNAs like MIR21, MIR92A. Then there is histone methylation, and there is long non-coding RNAs. So a lot of things are being worked out. A lot of things are being evaluated as far as predicting the risk of colorectal cancers are concerned. So these are the genomic biomarkers which are in the diagnostic space. Of course, there are genomic biomarkers which can be leveraged in the therapeutic space as well. And what we have seen is colorectal cancers with microsatellite instability, which are high, they have increased tumoral, peritumoral lymphocyte infiltration, and that gives us an opportunity to leverage the body's immunity with the help of immunotherapy in improving outcomes. So I'm sure most of our viewers must have come across this magic wonder drug called durvalumab, which was recently in the news as far as rectal cancer treatment is concerned. So, although that was just a phase 2 trial and it is still being evaluated for its effectiveness, but I see genomics and the utility of biomarkers coming into fore more significantly here on. Because to be honest, I'm sure you understand this, that currently we are treating cancer in four blocks. So it is like, to give you an example, it's like four states. For example, you have Karnataka, you have Madhya Pradesh, you have Maharashtra, you have Tamil Nadu, and each of these states, we have defined the treatment that people in these state will only get one specific type of treatment. So that doesn't work. That is not how it works. So every cancer has specific signatures, specific genomic markers, specific epigenomic changes, which we have to ascertain depending on the tumor. So every tumor is different, every individual is different, so every treatment has to be different as well. So that is where the genomic screening and biomarkers come into role, and that is how I see this evolving in the future.
And what do you think are the challenges to integrate this into the clinical practices? You are a clinician yourself.
So, I am a surgical oncologist, so I basically deal with colon cancer when it has already formed a tumor. Obviously, I would like to catch these patients who are likely to develop tumor much earlier in the the development of this malignancy. Uh, the problem with genomic screening is we are still in an infancy as far as we understand this concept entirely, because we are not sure whether the genomic screening, we are predicting that the patient is likely to develop a cancer, but we still don't know whether he is going to develop it. So of course, more research is required, because most of the studies that are focused on genomic biomarkers are retrospective for now. Of course, there are some tests which are going on prospectively, and we are evaluating whether genomics play a role and can be used as a standalone diagnostic and screening modality as far as diagnosing colorectal cancer is concerned. Of course, there's a lot of research that is happening as far as the therapeutics is concerned. As I mentioned, durvalumab is one of them. There is a niche trial which evaluates the role of nivolumab and ipilimumab in colorectal cancers. A lot of work has happened in the metastatic state. So that is when the colorectal cancer has already spread to the other parts of the body. We have seen very good progression-free survival as far as immunotherapy is concerned, where specific molecules are used as immune checkpoint inhibitors, depending on the genomic signatures of the tumor. Of course, I see that these molecules are going to be used much early on in the disease process. And since they have found utility in metastatic stages, I'm sure that they are going to be used much early on, maybe in the neoadjuvant setting, that is before the patient goes in for surgery and these things. One of the other problem with genomic screening, of course, is the cost that is involved, because these are kits which require a lot of laboratory and chemical-based reagents, and to make them available at the community level is going to be a task. But all these things can be addressed once you find the utility, then things can move on very fast. So yeah, that's how I see it.
Yeah, and I believe that by embracing the upcoming field of genomic biomarkers, and also, by targeting the therapies according to the genome, we can overcome the patient hurdles and fight the cancer much early on.
An example just comes to my mind. So you have a train which is going on a track, all right? So it's like an average risk person. At each stage where the gene mutation happens, it is like a train that is stepping off the track and going onto a different track. So the multiple such events throw the train off to an entirely different destination. So we as clinicians and professionals in the oncology space have an opportunity to evaluate and map each of these events where the train shifts off the track. So you have an APC mutation, you have a DCC mutation, you have KRAS mutation, you have P53 mutation. All these are breadcrumbs that nature throws in your path, which you can evaluate and try to bring the train back on track. So that's something that can be utilized. Of course, more research is required. We need to understand this in completeness and then make use of this to have a real clinical benefit, to be honest. Yeah.
So thank you so much, Dr. Shravan, for joining us today and enlightening us with colorectal cancer and how the treatment can be, advanced and how we can overcome the disease much early. Thank you so much.
Thank you so much, Dr. Manisha. I'm glad to be there on your platform. Thanks a lot.
Thank you.